Hi, my name is Matthew Mardis, and I'm an assistant professor at the UK College of Medicine, Department of Anesthesiology, and today we're going to discuss blood pressure monitoring. I have no disclosures or conflicts of interest to report. This lecture is a part of our keyword lecture series covering topics within the outline for initial certification in anesthesiology. The sections for this lecture are highlighted here. Specifically, we will focus on physics, monitoring, and devices today. Suggested readings include Miller's Anesthesia, particularly the chapter on cardiovascular monitoring, Barash's Clinical Anesthesia, chapter on monitoring techniques, and Morgan and McHale. Additionally, there are many other fantastic online sources, including Open Anesthesia, as well as further lectures covering blood pressure monitoring and hemodynamics on this channel. So why are we interested in blood pressure in the first place? Well, it is a fundamental cardiovascular vital sign included in the mandated standards for basic anesthetic monitoring. We can use pressure monitoring to give insight into well-being and prognosis of the patient, detect effects of illness or interventions, as well as calculate and derive other important parameters. Per the ASA Basic Anesthetic Monitoring Standards, which were last affirmed December of 2020, every patient receiving anesthesia shall have arterial blood pressure and heart rate determined and evaluated at least every 5 minutes. Every patient receiving general anesthesia shall have, in addition to the above, circulatory function continually evaluated by at least one of the following: palpation of a pulse, auscultation of heart sounds, monitoring of a tracing of intra-arterial pressure, ultrasound peripheral pulse monitoring, or pulse plethysmography or oximetry. To this end, arterial blood pressure can be monitored with intermittent or continuous and direct or indirect methods. Pressure, from a physics perspective, is typically thought of as a force exhibited over an area. The SI unit for pressure is a Pascal, or 1 Newton per meter squared. However, traditionally in medicine, blood pressure has been measured in millimeters of mercury. Millimeters of mercury is not to be confused with height measurement and has a standard definition, which is defined as the pressure exerted by a column of mercury 1 millimeter high with the density as listed below at standard gravity. Although devices, manometers, and transducers today don't typically use mercury, instruments in the past were calibrated as such, and the measurement of millimeters of mercury became the standard that's still reported today. The flow of blood is pulsatile, so that means rather than one pressure, there is a maximum and a minimum pressure value. These are known as the systolic and diastolic blood pressures. The mean arterial pressure is the average pressure in the arteries throughout one cardiac cycle. There are several ways that blood pressure can be estimated or measured. Starting with the non-invasive techniques. Typically, this involves some sort of cuff on an extremity that is inflated to the point that all blood flow ceases, and then slowly deflated while simultaneously monitoring some indicator of return of blood flow through the vessels underlying the cuff. For palpation, systolic blood pressure only can be determined by palpating a peripheral pulse, inflating a blood pressure cuff proximal to the location until the flow is occluded, releasing cuff pressure slowly, about 2 to 3 millimeters of mercury per heartbeat, and then finally measuring the cuff pressure at which the pulse is first felt again. This does not give you a diastolic blood pressure or mean arterial pressure measurement. Doppler ultrasound method is similar to palpation, but uses Doppler to establish the systolic blood pressure. Lastly, The finger cuff is the newest method and utilizes a volume clamp technique which allows continuous, non-invasive blood pressure monitoring by dynamically adjusting cuff pressure to maintain a constant finger artery volume. This is achieved by using a photoplethysmograph to measure finger artery diameter and a servo system to control the cuff pressure. Auscultation is similar, but uses Korotkov sounds, named after Nikolai Korotkov, a Russian physician who described them in 1905. These sounds are a complex series of audible signals created by turbulent arterial flow. In simple terms, the systolic pressure is assigned to the pressure at which the first sound is heard, and the diastolic to the point when the sounds disappear. The transition from the noisy turbulent flow to laminar quiet flow. Both the systolic blood pressure and the diastolic blood pressure can be determined. There is no direct mean arterial pressure measured, but it can be estimated using the systolic and diastolic blood pressures. In contemporary practice, automated non-invasive blood pressure monitors, also known as automated sphygmomanometers, employ the oscillometric method to estimate the arterial blood pressure. This method uses an occluding cuff to measure the pressure fluctuations that occur due to arterial pulsations. Pressure is simultaneously applied to the cuff while the pressure oscillations are monitored. A microprocessor analyzes the oscillations in the cuff produced by the pulsating artery. Pressure is applied to the cuff starting above the systolic blood pressure. The pressure is gradually lowered in a similar fashion to the auscultation methods. However, a microprocessor monitors the pulsations which appear in the cuff. With the oscillometric method, the systolic pressure is estimated using the maximum cuff pressure at which the pressure oscillations can be perceived. The mean arterial pressure is estimated by the cuff pressure at which the amplitude of the oscillations is the greatest. The diastolic blood pressure is estimated using the minimum cuff pressure at which the pressure fluctuations can be perceived. So, of importance, the mean arterial pressure is determined directly from the point of maximum oscillation. Thus, it is the most accurate measurement. Systolic and diastolic pressures are estimated based upon proprietary algorithms. Thus, the systolic and diastolic pressures derived from oscillometry are less accurate than the mean arterial pressure. Here is a representation of auscultation and oscillometric methods side by side. Oscillometry is what we typically use every day and allows us to monitor autonomously with our machines. It gives us the mean arterial pressure, which is arguably the most important value, as well as measurements of systolic and diastolic blood pressure. As we know, however, it is not perfect, and every system is prone to inaccuracies. Improper cuff size can lead to over or underestimation of blood pressure. You want to ensure that the cuff width is 40% the circumference of the extremity and the bladder length is 80% extremity circumference. The cuff bladder should be well placed over the artery, and with our more obese patients, a forearm cuff may give a more accurate measurement depending on cuff size. Next, I briefly will discuss a more emerging non-invasive pressure monitoring technique, that is the finger cuff volume clamp method. The essence of the volume clamp method involves clamping the artery to a constant volume by dynamically providing equal pressure on either side of the arterial wall. The volume is measured by a photoplethysmograph built into the cuff. The counter pressure is applied by an inflatable bladder inside the cuff and adjusted 1,000 times per second to keep the arterial volume constant. Continuous recording of the cuff pressure results in real-time finger pressure waveform. In summary, This method generates a reproduction of an arterial waveform without direct monitoring, which in hemodynamically stable patients correlates acceptably with invasive arterial pressure. However, this method may not be reliable in critically ill patients and does not allow blood sampling. The risk or delay of placing an arterial line is typically not substantial, but this is an emerging alternative method. Moving along, we will next discuss invasive arterial pressure monitoring. Intra-arterial blood pressure monitoring uses fluid-filled tubing to transmit the force of the pressure pulse wave to a pressure transducer that converts the displacement of a silicon crystal into voltage changes. These electrical signals are amplified, filtered, and displayed as the arterial pressure trace. Intra-arterial pressure transducing systems are subject to many potential errors based on the physical properties of fluid motion and the performance of the catheter transducer amplification system used to sense, process, and display the pressure pulse wave. Invasive blood pressure monitoring provides accurate and second-to-second monitoring, dysrhythmia analysis, access to arterial blood, and waveform analysis. Indications include, but are not limited to, if you can't obtain blood pressure by any other means, when you anticipate rapid changes in blood pressure, including use of vasoactive infusions, or when prompt control is important, pulmonary dysfunction, as well as certain surgical procedures. I have mentioned transducer a few times, but what exactly does that mean? A transducer is an electronic device that converts energy from one form, the mechanical force of a column of fluid, to another, the electrical signal which can be measured. The transducer commonly used in our arterial line systems is known as a Wheatstone bridge transducer. It uses resistors of different electrical resistance, two fixed, one variable, and one determined by change in pressure. When the top known resistors equal the bottom, then zero current flows through the galvanometer, G. However, when pressure is applied via fluid column, a flexible diaphragm stretches, which then changes the resistance of the variable and unknown resistor. The measured difference in current caused by the difference in resistance is used by algorithms to calculate the pressure waveform required for such changes. Additionally, modern-day strain gauges may have all resistors with variable resistances and more complex algorithms to convert current into the pressure waveform. Another important topic that relates back to the physics of monitoring is to what level the arterial pressure should be referenced. Because of the effects of gravity on the pressure within columns of fluids, the pressure varies with vertical elevation. When the patient is level and the transducer is at the same level of the patient, this makes no difference. However, when the patient is not level with their back elevated in Trendelenburg or reverse Trendelenburg, or when the transducer is in a different vertical location than the patient, then discrepancies occur. There is a difference of about 0.7 millimeters of mercury for blood pressure for every centimeter difference in height. Therefore, if you measure pressure in an arm or a leg with a non-invasive device, for example, a blood pressure cuff, you must correct the pressure reading by this amount to determine the pressure in the brain, if that is what you want to reference. If you measure the pressure with an invasive arterial line, you should place the transducer at the level of this reference point. Here's an example picture demonstrating the difference in measured blood pressure. With the non-invasive blood pressure cuff on an elevated arm, the blood pressure reading will be underestimated. An extremity below a level body will be overestimated, each by a factor of 0.7 millimeters of mercury per centimeter in height difference. This is another example of pressure difference. When the head is elevated at about 30 degrees, the pressure in the head is about 15 to 20 millimeters of mercury lower than at the level of the heart, and the head to the ankles is about a 40 to 50 millimeter of mercury pressure difference. Notably, with a leveled arterial line, the elevation of one limb or another does not matter for an intra-arterial invasive blood pressure measurement. However, the zeroing and the level of the transducer matters. As depicted, the patient's measured non-invasive measurements vary, and the direct arterial lines show the same pressure. This is because the transducer is zeroed at the level of the heart. If one needs to focus on mean arterial pressure perfusing the brain, which would be lower in a sitting position, for example, one could zero at the heart and move the transducer to the level of the head, or make calculations based off of the height difference. This next section further expands upon the physics involved within the invasive arterial monitoring system. Going back to the oscillometry and pulsatile flow of blood, one can think of the arterial pulse as a harmonic oscillator. In essence, the displayed pressure waveform is a summation of both antigrade and retrograde sine waves, each with its own frequency, amplitude, and phase shift. This means that the system, at equilibrium, once disturbed, experiences a restoring force in a proportional fashion. In our arterial line system, we have friction, and thus a property that can be described as dissipation of energy that drives the system back to equilibrium. This property is known as damping. The picture here represents a simple illustration of the summation of harmonic waves that make up the arterial waveform as we know it. Natural frequency describes the frequency at which the measuring system is most prone to resonance. In other words, the frequency with which a system will oscillate after it is disturbed by a non-sustained stimulus. Resonance is the amplification of a signal when its frequency is close to the natural frequency of a system. As mentioned previously, damping describes the tendency for fluid in the measuring system to extinguish motion. A value of 1 means there is no resonance, or no amplification of signals near the natural frequency. If less than 0.3, there is prolonged resonance, or increased amplification of signal near the natural frequency of the system. We typically never achieve perfection in our system, but the optimal zone seems to be somewhere between 0.6 and 0.7. Since damping is the tendency for fluid in the measuring system to extinguish motion, an underdamped system leads to overestimation. A system with minimal damping will reverberate, and the natural frequency of the system will amplify the waveforms. The pressure measured by the transducer will be higher than the actual pressure. An overdamped system underestimates values. With overdamping, some of the higher frequency harmonic waveforms will be lost. This will lead to broad flat waves with systolic and diastolic coming closer to the mean arterial pressure. Here's a diagram of an underdamped system. Notice how the waveform appears amplified. The systolic and diastolic blood pressures are exaggerated with distorted waveform with multiple notches. On the other hand, An overdamped system will have a diminished pulse pressure with a flattened shape. There will be a low signal amplification compared to a normal waveform. Of note, in both cases, the mean arterial pressure tends to correlate accurately. The fast flush test is used to test natural frequency and damping in the typical arterial line pressure transducer system. To do this, open the fast flush valve and expose the system to 300 millimeter mercury pressure from the pressure bag, and then quickly close it. The oscillations that follow can help determine some resonance characteristics of the system. Fast flush with system open to the patient, pull to create a square waveform and release. The natural frequency can be measured or estimated by measuring the period of one cycle of adjacent oscillation peaks. Using the grid paper, which is moving at a speed of 25 millimeters per second, we can find the natural frequency is 14.7 hertz in this example. In an underdamped system, you would likely see multiple artifacts in the waveform, but sometimes it's not obvious. If you were to fast flush, you would note an increase in oscillations following the flush due to the reduced damping permitting less dissipation of energy. In an overdamped system, you would likely see a flattened waveform with low pulse pressure and possibly loss of the dichrotic notch. If you were to fast flush, you would note a failure to oscillate normally or reduced oscillation. Overdamping is the much more common occurrence with our modern-day system designs. This can occur with inadequate pressure in the pressure bag, loose connections, kinks, air bubbles, or clot in the line, tubing that is too compliant such as IV extension tubing, or increased length of tubing and additional stopcocks. Underdamping is much less common by design, but can be caused by things such as excessively stiff tubing, defective transducers, an excessively short system, or a catheter flailing in an artery. Some key points for the end of this lecture. Pay attention to your waveform as it can vary based on many parameters. Flush test as appropriate, making sure the tubing is primed appropriately. Pay attention to the level of your transducer, especially with respect to where the reference zero location is at. The patient and the bed positioning can change. And just appreciate the modern conveniences of having programs do these intricate calculations, but know that if needed, palpation and auscultation can be completed quickly and with no electronics needed. Lastly, this is just a reminder to take a moment and measure your own blood pressure if you haven't done so in a while. Whether you own the materials to do so or need to visit a measuring station or clinic, this is important. Just as you do this, take note of the physics. I hope you learned something from this lecture today. That is all for me today. Hope everyone has a great day. Thank you.